This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to provide you with an overview of asthma.
First, let me talk to you about the Global Initiative for Asthma, also known as GINA. This is an international assembly of volunteer experts from 45 countries who meet twice each year prior to the American Thoracic Society and European Respiratory Society national meetings. In this work group, the literature is reviewed and recommendations about therapies are provided. Every year, the GINA guidelines are updated. There's a website for their work at www.ginaasthma.org. GINA defines asthma as a heterogeneous disease, usually characterized by chronic airway inflammation and airway hyperresponsiveness. It's defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough that vary over time and in intensity, together with variable expiratory airflow limitation. Asthma is a major problem worldwide where there are 300 million cases prevalent. The cost to society is great. Asthma is a major cause of missed work or school and accounts for up to 2% of health care costs worldwide. Asthma increases disability-adjusted life years and has significant annual cost in the United States. Let's turn our attention to risk factors for asthma. We know asthma is familial and there are certainly genetic abnormalities, but these are not well described. There are abnormalities in lung development associated with asthma. Asthma is associated with aging, sex, that is, male more common than female, socioeconomic status, that's to say, in lower socioeconomic status, there is a higher prevalence of asthma and is associated with recurrent infections. The role of viruses in adult asthma is fairly well worked out. Asthma, especially exacerbations of asthma, are associated with respiratory syncytial virus, rhinovirus, coronavirus, human metapneumonia virus, and influenza virus. Viral infections commonly trigger asthma exacerbations in up to 50% of exacerbations. Viral infections cause cytopathic epithelial damage and increase cytokine production, which bring in inflammatory mediators. There's an actual airway epithelial viral infection seen pathologically, and patients with asthma don't have more frequent exacerbations, but when they do exacerbate, the episodes tend to be more severe and longer. Here's a slide of pathology from a patient with asthma flare showing that the epithelium is inflamed and there are viral inclusion bodies as well as syncytial cells, which are aggregates of individual cells that form a single larger cell by aggregating. Typical viral cytopathic changes of acute asthma exacerbation brought on by viral infection. Nocturnal asthma symptoms are common and may indicate poorly controlled asthma. There's a circadian pattern of asthma with patients best in the late afternoon and worst at about 4 a.m. The circadian variation in airflow varies in healthy people between 5 and 8%, but in asthmatic can vary as much as 50% from afternoon to early morning hours. Hormones are also related to asthma, especially circadian variation. There's a blunted cortisol response after midnight to ACTH, and low cortisol levels correspond to worsened asthma control and airways hyperreactivity. There's an increased pro-inflammatory response to the hormone melatonin and increased cholinergic tone. Effects of normal nocturnal hypoventilation are exaggerated in asthma at nighttime. I'd like to review the classification of COPD because there is sometimes quite a bit of confusion about the nomenclature. I had shown this slide during my COPD talk, but it's worth reviewing again from an asthma perspective. Once again, as you can see here, there is significant overlap between the most common forms of COPD, chronic bronchitis and emphysema. Although we frequently see patients, usually smokers or ex-smokers, with chronic bronchitis and no clinical emphysema or vice versa, the majority of our patients with smoking-related COPD have at least some chronic bronchitis and some emphysema. This may be due to the degree of smoking exposure or to genetic susceptibility. As you can see here, many patients with asthma have features overlapping with COPD. Patients with this overlap were previously referred to as having ACOS, or asthma COPD overlap syndrome. The GINA 2017 panel recommended removing the word syndrome when describing the population. I had told you during my COPD talk that I would explain why that was true. The reason they had the word syndrome removed is because the feeling now is that we are really not talking about a distinct syndrome, but rather patients with asthma COPD overlap simply have contributions from simultaneous related obstructive lung diseases to the common final pathway of airway obstruction. By dropping the word syndrome, clinicians are more likely to focus on the individual components, illnesses comprising the overlap. The yellow rectangle represents obstruction and shows that some patients with chronic bronchitis and emphysema have no obstruction. In addition, most asthmatics at some time will show near complete resolution of obstruction as indicated by the part of the asthma outside of the rectangular obstruction box here. For this reason, we do not refer to asthmatics who clear their obstruction at times as COPD patients. For that matter, it's recommended that patients with chronic bronchitis and with emphysema that have no obstruction be referred to as simply chronic bronchitis or emphysema patients. From this diagram, you can see that to have COPD, you must have persistent airways obstruction associated with chronic bronchitis, emphysema, or asthma that does not completely reverse.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.